Ladies and gentlemen, welcome to today's lecture on the pathophysiology, clinical presentations, and management strategies of graft versus host disease, GVHD. In this comprehensive session, we will delve into the intricate immune mechanisms involved in the development of GVHD and explore various aspects of this complex condition. Let us embark on this journey of knowledge and gain a deeper understanding of GVHD. Graft versus host disease occurs when donor T cells attack recipient tissues. This is triggered by pro-inflammatory cytokines, which activate recipient antigen-presenting cells and stimulate an immune response that damages target organs. Additional immune cells contribute to tissue damage and inflammation. The major histocompatibility complex, MHC, is crucial in graft versus host disease, GVHD. Discrepancies in the MHC molecules between donor and recipient trigger an abnormal immune response, leading to GVHD severity. Additionally, minor histocompatibility antigens contribute to the disease's progression. In the video segment on acute GVHD, we discussed its clinical presentation, grading systems, and management strategies. Acute GVHD affects the skin, gastrointestinal tract, and liver, presenting with a rash, diarrhea, abdominal pain, jaundice, and enlarged liver and spleen. We use grading systems like Glucksberg and NIH consensus criteria to assess the severity of acute GVHD, considering organ involvement, symptom severity, and lab results. First-line treatment involves corticosteroids like prednisone or methylprednisolone, which are potent immunosuppressive agents. If acute GVHD doesn't respond to steroids, we may consider additional immunosuppressive agents like calcineurin inhibitors, mycophenolate mofetil, or monoclonal antibodies targeting T-cell activation pathways. Chronic GVHD, which usually occurs beyond 100 days after transplantation, presents as a persistent systemic autoimmune syndrome affecting multiple organs. Cutaneous, gastrointestinal, hepatic, musculoskeletal, and pulmonary manifestations are commonly seen. The diagnosis of chronic GVHD is made based on the presence of specific clinical features in conjunction with histopathological findings consistent with GVHD in involved organs. The National Institutes of Health organ-specific scoring system is commonly used to grade the severity of chronic GVHD. Treatment strategies for chronic GVHD aim to control immunological dysregulation and reduce tissue damage. Systemic immunosuppressive agents, including corticosteroids, calcineurin inhibitors, mycophenolate mofetil, and sirolimus, are typically utilized. Targeted therapies, such as extracorporeal photopheresis and rituximab, have also shown promising results in certain cases. Gastrointestinal involvement in GVHD presents with symptoms like diarrhea, abdominal pain, nausea, and vomiting. Endoscopy reveals mucosal erythema, ulcerations, and loss of architecture. Biopsies confirm the diagnosis and assist in differentiating it from other GI disorders. Management includes supportive measures and pharmacological therapy. Cutaneous involvement in GVHD presents as a maculopapular rash in acute cases, spreading from the face to the body. Chronic cases present as lichenoid eruptions or scleroderma-like changes. Treatment includes topical corticosteroids, phototherapy, systemic immunosuppressants, and innovative therapies. Hepatic involvement in GVHD presents as a cholestatic syndrome characterized by elevated bilirubin, alkaline phosphatase, and transaminases. Clinical features may include hepatomegaly, jaundice, and pruritus. Liver biopsy is crucial to confirm the diagnosis and differentiate GVHD from other causes of liver dysfunction. Histopathological examination of liver biopsies reveals bile duct injury, periportal inflammation, endothelial injury, cholestasis, and hepatocyte apoptosis. Confluent necrosis can occur in severe cases. The mainstay of management for hepatic GVHD involves the use of systemic corticosteroids, preferably in combination with calcineurin inhibitors. Monitoring liver biochemistry and adjusting immunosuppressive therapy accordingly is crucial in preventing disease progression and hepatic failure. To prevent GVHD, various prophylactic approaches are used. Pharmacological agents like calcineurin inhibitors and biological drugs are commonly employed. T-cell depletion techniques and graft manipulation methods such as haploidentical transplantation are also used to reduce the risk of GVHD. In summary, the use of biomarkers, such as cytokines, chemokines, and genetic factors, can assist in diagnosing, assessing the risk, and monitoring graft versus host disease, GVHD. Various markers have shown promise in identifying and predicting the severity of GVHD, including IL-2 receptor alpha chain, STNFR1, HGF, and genetic polymorphisms. Genetic profiling can aid in personalized treatment approaches. The graft versus host disease, GVHD, Video explains how donor T cells in allogeneic stem cell transplantation can target residual cancer cells, reducing the risk of relapse. This immune-mediated anti-tumor activity is important in managing transplantation outcomes and improving patient prognosis. Various strategies to enhance the graft versus leukemia (GVL) effect are being studied. The use of mesenchymal stem cell therapy, extracorporeal photopheresis, and Janus kinase inhibitors shows promise in treating refractory graft versus host disease, offering hope for individuals who do not respond to traditional treatments. Graft versus host disease can have a significant impact on the long-term health and quality of life of transplant recipients. Chronic GVHD, in particular, can lead to various late effects and complications. In long-term survivorship after GVHD, patients may experience symptoms related to chronic organ damage, including pulmonary fibrosis, bronchiolitis obliterans, scleroderma-like skin changes, and secondary malignancies. Monitoring and managing late effects of GVHD require a multidisciplinary approach involving pulmonologists, dermatologists, gastroenterologists, and oncologists. Additional supportive care, such as rehabilitation, social and psychological support, vaccination, and surveillance for secondary malignancies, plays a crucial role in improving long-term outcomes. In conclusion, graft versus host disease is a complex condition stemming from the interaction between donor and recipient immune systems. Understanding its causes, symptoms, and treatment is crucial for healthcare professionals involved in transplant care. This session has provided a comprehensive overview of GVHD, covering its pathophysiology, clinical manifestations, management options, and future prospects. We hope this knowledge enhances your understanding of this challenging disease.